Good morning. I'm Paige Winfield Cunningham, a health policy reporter here at the Washington Post and author of the Health 202 newsletter. And I'm pleased to welcome my first guest this morning, Dr. Vivek Murthy, who was the 19th Surgeon General under President Obama. Welcome to the program, Dr. Murthy.
Thank you so much, Paige. It's great to be with you today.
Our topic is health preparedness in the pandemic, and I want to start off by asking you about some of the top stories today. My colleagues reported earlier this week that the FDA has been preparing sort of a stricter standard for getting a coronavirus vaccine approved for emergency use later this year. President Trump was asked about that plan last night and seemed to dismiss it, called it a political play, and suggested that he would not give his approval on that stricter guidance. I want to ask you, do you think stricter standards would be appropriate at this juncture? As you know, we do see a fair number of Americans seem to be a bit skeptical of a vaccine. Would you like to see stricter standards?
Well, Paige, I was glad to see the story that your paper reported about the guidance being worked on and hopefully soon issued. Because one of the things that the scientific community has been calling for are clear standards for how this vaccine will meet safety and effectiveness. And that has to be clear ahead of time because there's already been too many instances in the last 6 months of how politics has really overtaken science when it comes to decision making from the administration, and in particular from the FDA when it came to the decision they made to issue an EUA, an emergency use authorization for hydroxychloroquine, and later the misstatements that they made about plasma, convalescent plasma. And so it's all the more important, given the hesitancy we know exists in the population already, with 50% of people or more saying they wouldn't take a vaccine even if it was available today. It's really important that those standards are clear, that they're put out in advance, and that they're actually observed and honored when a decision time comes for an emergency use authorization.
So to kind of get a little bit more into what an EUA would mean or how you would issue one, I know the idea has been that these companies would be able to observe a relatively small number of people who had been given the vaccine in a placebo, perhaps over just a couple of weeks after receiving the final dose, and then would be able to apply to the FDA for an EUA. And it sounds like under this potential new guidance, companies would be required to observe people for, I believe, a median of 2 months. So do you think that time frame needs to be lengthened so that we can be more assured, I suppose, of the efficacy of a vaccine?
Well, there were actually several things that were put out in these, or these that are being drafted in these guidelines and potentially included that I think are important. One is what you mentioned, the 2 month time frame, and that's really around safety. 2 months after the last dose of the vaccine, to be able to assess whether an adverse event has taken place. Now, will that catch every possible adverse event? No, but 2 months is a reasonable time frame to consider. But there are other elements of these guidelines that the FDA has been working on that are important. They had also said, for example, that an external advisory group has to weigh in prior to an emergency use authorization being issued. That is critical. This is an important source of accountability. These are external scientists who would really consider this vaccine in the context of a public hearing. So the public would be able to listen and to engage and look at the data. They'd also said that there need to be at least 50 cases in the placebo group, and there also needed to be a plan presented by the manufacturer for how to manufacture the vaccine at scale, how to do it safely, and also how to track adverse events after the EUA was issued. These are all important planks to ensuring that it's more likely that the vaccine that is issued in EUA would be safe and effective. Um, so the truth is, and the question is really at this point, will these guidelines be honored? Will the FDA be allowed to issue them without interference from the leadership in Health and Human Services and from the White House? And that's a question that the entire scientific community and frankly the public is, I think, waiting to hear the answer to.
Well, and based on Trump's comments yesterday, are you concerned that he will try to block this? I believe the guidance is at OMB being considered by OMB right now. And if he does that, what is that going to do to the public's confidence in the safety and efficacy of a COVID vaccine?
The comments the president made yesterday were not. I think people are already worried about interference what scientists are recommending, and to say that the White House would potentially overrule this guidance was not a move that I think increased people's faith that this process would be carried through with integrity and with prioritizing science. Look, everybody should have a chance to weigh in and give an opinion on these guidelines of the administration. But what's really important is what is driving the boat? Is it science or is it politics? That simple, and it's that important to make that clear. And right now, the bar needs to be high, and because of the missteps in the past. So there has to be transparency in how this decision is being made. The public needs to hear from staff scientists at the FDA as well, not just political appointees. We need to have confidence that the people who had the most experience evaluating vaccines and improving them are the ones driving decisions.
And what are ways you referenced earlier the polls that show the trust Americans have in a COVID vaccine isn't great at this point, and it actually seems to have fallen from where we saw from levels we saw in the spring. What should the message be from the Trump administration right now about a COVID vaccine? And then also, Democratic nominee Joe Biden, who potentially could be in a situation in January where he's the one who is in charge of trying to convince people to take a vaccine.
Well, I think, if I was advising the Trump administration, what I would tell them at this point is that you have to let science guide your way on this vaccine. You have to get politics out of decisions about whether they issue the authorization, about timelines, and in your communication as well, you've got to be crystal clear that the people driving this are going to be the scientists at the FDA, that there will also be transparency, that the data that you are using to evaluate a vaccine candidate will be made available to the public so that the scientific community can also weigh in on that. There's a lot of ground to make up here. The Kaiser Family Foundation's recent poll earlier in September showed that 54% of people polled said that they would not take a vaccine if it was available today. That is staggering. And if we want to be able to utilize a vaccine to move toward herd immunity, we're going to need the vast majority of the American public to recognize and trust that this is safe and then to take that vaccine. At this point, we're not in a situation where we're assured that that's possible. So we've got trust to rebuild and a lot of ground to make up.
Let's talk about the pharmaceutical companies for a minute. And I think we have four vaccines that are in final stage trials at this point. Johnson & Johnson announced that they're entering the stage 3 this week. And I know a number of the companies, or at least one, I'm not sure if the others have said that they're going to release more data than they would ordinarily. Are you satisfied with the level of transparency that we're seeing from these developers?
Well, I think we've seen some positive moves recently. I think having a few companies release their protocols, I think it was a step in the right direction. I think having the companies also sign a letter together to say that there were certain standards that they wanted to be met in terms of trial completion before an EUA was actually issued or considered, I think was a step in the right direction. I think the real question is going to be what happens when the time for a potential authorization comes. Will that data be made available? Here's one thing I'm concerned about. I'm concerned that in this process over the last 6 months, we have seen what in the scientific community many of us have called publication by press release. And what I mean by that is typically when you want to get out scientific developments, you have it peer reviewed and it gets published in a journal. And the point is that it's rigorously evaluated before you put it out for public consumption. But in many cases, what's happened with the vaccine trials, especially the early stage trials, was that companies published press releases saying, we have these findings, and even before it was evaluated by a group of peer scientists. And that allowed information to spread in the public before it was thoroughly vetted. We can't afford for that to happen. What I don't want to see is one of these companies issue a press release saying, we've got it, we've done it, we have a vaccine that works, without the opportunity for proper evaluation by scientists. That would be a mistake, and I hope that they all guard against that.
Well, and it does seem like they have an extraordinary amount of pressure, of course, to get a vaccine approved. There, I know, has been some discussion about who would be the first people prioritized to get a vaccine under an EUA, and there's talk, of course, about frontline medical workers, the elderly. Who, in your opinion, should be a top priority for getting a vaccine first?
Well, the National Academies of Medicine, Science, and Engineering have done a great job actually at putting together a draft of these priority groups, and they will be submitting it, to the CDC, and to the NIH and to others in HHS for consideration. And ultimately, the decision will be made by the government on these priority groups. But I do think that they're on the right track, because what they have done in their tier one is prioritized healthcare workers who are on the front lines, who have the greatest risk of exposure to COVID-19. They've also prioritized people who are at higher risk, and this includes the elderly. It includes people who have serious medical conditions, and we've seen, at this point, we've just crossed a really tragic milestone of 200,000 lives that we have lost because of COVID-19. But we know that we're not at the end, and so protecting the most vulnerable has to be our priority. We've got to get them vaccine first.
Yesterday, there was a hearing in Congress with the top scientists in the administration, Dr. Fauci and, of course, Robert Redfield. And, of course, they were asked again about the timeline for when a vaccine might be broadly available. And they had both pointed to next spring as a point. Do you agree with that timeline based on what you've seen? Is that a realistic time frame?
Well, I think targeting next spring for widespread access to a vaccine, meaning that you've gotten through your high priority groups, you've vaccinated them, and you're moving on to tier two and tier three groups. That's an optimistic timeline. I think it's possible, but it's optimistic. We would need to get a vaccine pretty quickly that passed the evaluation process and proved it was both safe and effective. We would need to have one of the most efficient and effective delivery processes for a vaccine that we've ever had in the history of this country. And we're going to have to build that. And plans need to be put together. I hope they've already been put together by the administration to actually deliver on that. But if all of that takes place, and if public trust is restored in this vaccine such that people are willing to take it, then it is possible that by the spring we could see widespread access to the vaccine. Keep in mind one last thing, though. The leading candidates for the vaccine are two-dose vaccines. That means that you don't need to just get someone in the clinic the first time, but either 21 or 28 days later, depending on the vaccine that's ultimately approved, you will need to bring people in for a second shot. You will also need to have very high quality and integrated data systems in place so you can track who has been vaccinated, so that if you have pockets that have not been vaccinated, you can target your efforts and your resources there. It's a lot to come together, to pull together at this moment in time, but it's what we need to do to ultimately protect the country from further death and further illness as a result of COVID-19.
Well, and you mentioned that the CDC released a vaccine distribution plan last week. It sounds like you've taken a look at that. What do you think overall? What are strong points, any weak points there? It sounds like they're working through existing systems, but what's your analysis of that?
Yeah, so the plan that they put together last time was reassuring on a couple of counts. One is it did hit a number of the critical areas that you'd want to cover when it comes to vaccine distribution, thinking about who your partner should be, thinking about systems and mechanisms for transporting the vaccine, recognizing that one of the vaccine candidates in particular, the Pfizer vaccine, requires cold storage at dry ice temperatures, which is between -70 to -80, which presents a huge logistical challenge. There was thought given to how we track data as well and make sure that we are cooperating with states and working in close partnership with them. So there was a lot of, they hit a lot of the right notes in terms of acknowledging topics that were critical. The real challenge now, though, is can they actually get it right in terms of execution? We know that putting plans together is one thing, executing them is another. But the fact that this kind of guidance was put out reassures me that many of the scientists that I know, having worked with them at the CDC, and who have great expertise, knowing that those scientists are there and still there, that they're working, that they have the right ideas, that they can still help guide us through this crisis is to me reassuring. What we need to now do is let them do their work without interference. And I think we'll be in a much better place in addressing this virus.
I know Joe Biden has released some guidelines for how he would go about distributing a vaccine. Have you taken a look at that? And what do you think would be the biggest differences between his approach and the one the Trump administration seems to be taking?
Well, Vice President Biden has been really concerned about vaccine distribution for quite a while now. And the reason is because during his time in the White House with President Obama, there were a number of outbreaks that they had to deal with, from H1N1 to Ebola to Zika. But with the H1N1 in particular, they had to think through how to rapidly and effectively get a vaccine out to a large portion of the population. So that challenge is familiar to him. He appreciates, and I think is approaching this task with humility, recognizing that we have, in some ways, even greater barriers now because of the challenges with public trust. And so, as he's thought about a distribution plan, he's prioritizing many of the key elements that would not surprise you. He recognizes the importance of strong data systems to understand who's gotten the vaccine so we can deliver resources. He understands how important it is to figure out storage and transportation of these vaccines. He knows how important partnerships are, not just with state governments, but also with health systems, with large big box and pharmacies that are going to be important sites of distribution, as well as with schools and employers. We're going to be critical partners here as well. I think the bottom line, though, is he understands that you can't just talk a good game when it comes to vaccine distribution, but in the execution, you've got to really put your shoulder to the wheel and build those partnerships, restore trust, and communicate effectively and regularly with the public. I'll lastly say this, Paige, because this is a theme I think that he has touched on before that I firmly believe from my own experiences with Ebola and Zika, which is that in a pandemic response, public trust is one of your most important resources. If you don't have it, then people will doubt everything you say and your recommendations, even when they're legitimate scientific recommendations. And in this case, the stakes are extraordinarily high. So having a leader and having a leadership team that communicates regularly, transparently, and truthfully with the public, that shares information not just when it's convenient, but even when it's hard. So as someone who talks not just about the successes, but about the failures and how we're going to rectify those failures, that is absolutely essential in a pandemic response. And you've seen that from Republican and Democratic governors alike, who have, in select cases, done an extraordinary job of leading their states and communicating well in this time of crisis.
Well, I know we could talk about vaccines forever, and I'd love to pick your brain, but want to ask you a little bit about, as we look forward to the fall and winter, as we're still dealing with this virus, let's imagine for a minute that you were still Surgeon General and part of the coronavirus task force. What advice would you be giving to the president as we look ahead to the cold season, especially as we see the cases of the flu starting now, presumably to rise through the next couple of months?
Yeah, so I'm worried about the fall for a couple of reasons. You mentioned flu, and we should be very concerned about flu. Fortunately, many of the precautions we're trying to get people to take to prevent COVID-19 transmission will actually help prevent flu transmission as well. That's a good news. So hand hygiene, distancing, wearing masks, those will all help. But we really also need people to take the vaccine as well, the flu vaccine. Flu vaccine is not perfect. I think most people know that at this point. But every year in the United States, we save millions of people from infection and from complications, potential complications, because they get the flu vaccine. And this is true over the last many years. And so what's really important here is that people get vaccinated. In Australia, a country that took precautions seriously, like hand hygiene and distancing, and that tripled its vaccination rate for flu, they saw a 99% decline in flu cases this year compared to last year. And keep in mind, Australia being the southern hemisphere experienced flu season ahead of us. So I'm worried about flu. I'm worried about cold weather bringing people indoors, and we know that indoors is a much higher, setting for transmission than outdoor settings. So this makes it all the more important that we are being really cautious and wearing our masks, that we are washing our hands, that we are keeping our distance. And I know people are getting tired of this. In my own family, I've got two small kids, 4 and 2, and my wife, and we're living with with my parents and my sister and my grandmother and brother-in-law and 3 cats. It's a crazy, chaotic time, and I know many families are going through this upheaval, and it gets tiring after a while. And we'll ask the question, how long do we have to do this? But this is the moment, I think, when we've got to be especially careful, because we've seen that in other instances when we let our guard down, when localities and states relaxed restrictions too early, as happened at the beginning of the summer, we saw surges. And so we got to be vigilant right now, follow these rules, and we've shown that if we do, they can keep us safe.
Well, that's all the time we have for today. Thank you so much for such an interesting conversation, Dr. Murthy.
Well, thank you so much, Paige. It's great to be with you, and my best wishes to you, your family, and to all who are listening. Stay safe and stay well, everyone.
Please stay with us. I will be back with Dr. Chinazo Cunningham in just a few minutes.
How do things work? Things that give so much joy and happiness. How can the right support drive optimal health? How can shared intelligence spark brilliant solutions? How can we improve the quality of healthcare and make it more affordable? How do we bring everything together so that healthcare works for all of us? We know how. We are the how. Optum. How well gets done.
Good morning. I'm Elise Labott of American University, and I'm joined by John Prince, CEO of Optum RX, and Dr. Reena Pandey, Chief Medical Officer of Able2. Reena, let's start with you and kind of branch out this conversation a little bit. We've seen that the COVID-19 pandemic has really exposed and even exacerbated serious disparities in healthcare for the most vulnerable populations, lower income communities, minorities, the elderly. How do we deal with this as an acute issue while also pushing for that kind of systemic change that we know needs to take place?
Yeah, thanks so much, Elise, and it's great to be here with you and with John to talk about this topic. I think the pandemic really has revealed, it really has laid bare deep-rooted inequities in our healthcare system. As the CMO of Able2, I lead a virtual mental health company. So we're providing mental health care all around the country. And we've seen real disparities in the mental health impact of this pandemic. Vulnerable communities took a particularly devastating hit, as you pointed out, whether they're elderly adults or folks of different racial and ethnic backgrounds who were particularly hard hit with the COVID pandemic. And that has made it very clear that we've got some deep-rooted challenges within our healthcare system that we need to tackle. Just to focus on the mental health impact for just a moment, we've been treating folks for the last decade virtually, providing really high quality and evidence-based mental health care. And we've seen a lot of the mental health impacts of the pandemic. So whether it was a result of financial insecurities or social isolation and loneliness resulting from the public health measures that were put in place, or the uncertainties that have led to stress and anxiety, our engagement has gone up 65%. So many more people are seeking mental health services, and we're fortunate that we're in a position to be able to deliver them, but it just speaks to the underlying needs that people are facing and the suffering that's going on across the nation.
John, well, 65% increase in mental health, that's a lot. Let me ask you what you're learning about some of these growing trends like telemedicine and virtual care. We talked about the increased reliance on digital methods of healthcare. How do we improve these services moving forward? And there's been this increase in multiple chronic conditions that people may not be able to get out to the doctor and keep up with treatment.
Well, thank you, Elise. So there's a lot going on in the healthcare system. I think the pandemic highlighted really two key trends that have been exposed. The first, as Reena mentioned, is the rising toll around mental health in the United States and the need for support. And the second one is around the number of polychronics in the United States. And those are individuals with 3 or more health conditions. Just to add a little more data around what Reena said around her number of visits we saw a double-digit increase in the number of people that needed antidepressant or anti-anxiety medications on those first couple of weeks. As a response, we've been very focused on making sure people get the needed pharmacy needs that they have in this pandemic. So we've been adding additional general pharmacies. General pharmacy is the largest pharmacy dedicated to behavioral health in the United States. We have 540 locations, and we've added 27 during the pandemic. Built them and actually made sure we met this market need. They've had phenomenal results, increasing medication adherence by 90% for individuals, which drives down ER visits and hospitalization, but there's more needed. Another key trend in the market right now has been about polychronics. Individuals with 3 or more health conditions, 28% of Americans are polychronic. Those individuals have not seen the doctor, not gotten the treatment they needed, and we're super focused on how we can create a healthcare system to support those individuals that need the care.
Well, let's talk about that. We're seeing this increased reliance on digital telemedicine, virtual care, in-home care, if you will. People can't get out to multiple doctors. How do you improve upon these services as we move forward?
Great question. As you look at the market today, Optum's customers are just like everybody else. They're highly adopting virtual services as well as a focus on the home setting. There are a couple of key areas that we've been focusing on. First is making sure people get the medications they need at home, how we can support them with home infusion. Think about those most vulnerable patients that can't get to the doctor or don't feel safe there, as well as virtual care. And I'll just give you some data around what's happened over the last 6 months. In terms of use of virtual technology, we've seen a 78% increase year over year in people using our digital tools to get healthy. We've seen a rapid adoption of home infusion. People that used to feel they could go to the doctor's office or the outpatient setting in the hospital have shifted to a home infusion. Those are safer, more effective, and especially for the most vulnerable, a better setting for them. We've seen a 12% increase in that in year over year. And lastly is virtual visits. Virtual visits have exploded. We have a huge cadre of healthcare providers at Optum. They did 800,000 virtual consultations in April and May alone. I mean, that gives you an idea of the scale that's needed and the desire for consumers to have a better health solution in the market.
Rena, I feel like this is a watershed moment for digital services, but mental health, you don't really think of that as a kind of in-home service. It lending itself to a virtual space. How do we, end that stigma and increase those type of services?
Yeah, I'm glad you asked the question. It's interesting. There's actually a lot of rich evidence to support delivery of mental health through technology. Some of our own data at Able2 demonstrating very good clinical outcomes for patients who participate in care either by telephone or by video through our technology platform. And there's data in the published literature actually that suggests that telephonic or video delivered psychotherapy is equally efficacious as face-to-face. Actually, I think mental health is one of the areas where telehealth can be applied quite successfully. I think it really has been a watershed moment for patients, for providers, for payers, to really appreciate the value of technology-enabled care delivery. On the other hand, I think it has highlighted some of the challenges. Back to your first question, I think it is another area where some of the disparities in healthcare become apparent. And so I think as we march forward, finding the places where technology can be applied successfully, like in mental health, but then also acknowledging where we need to be creative in marrying face-to-face and technological means to get patients the care they need.
Well, clearly there's an opportunity here to make the healthcare experience more user-friendly for people. In the end, it's really about helping people live healthier lives and working together as an industry. I know at Optum, you're really concerned about that. So Dr. Rena Pandy, Chief Medical Officer of Able2, and John Prince, CEO of Optum RX. Thanks for joining me. And now back to Paige Cunningham.
This created the perfect storm for people who would get the disease. Their living environment, living in dense environments, allowed for increased spread. And once they had the disease, they had other illnesses that made outcome more likely to be not good.
Well, welcome back. If you're just joining us, I'm Paige Winfield Cunningham, the health policy reporter here at the Washington Post, and I'm pleased to welcome our next guest, Dr. Chinazo Cunningham. We're not related, in case anyone was wondering. She's a professor of medicine at the Albert Einstein School of Medicine in the Bronx, New York City. Welcome to Washington Post Live, Dr. Cunningham.
Thank you so much, Paige. I'm happy to be here.
As the video before this noted, we have seen higher rates of both infection and death among Blacks and Hispanics in this country, especially compared to whites and Asians. Can you give us what you see as the top reasons for that disparity?
Absolutely. So it's actually pretty complicated that there are many reasons, sort of levels of reasons for these disparities. So when I think about it, I think at the individual level, at the sort of healthcare system level, and then at societal level. And so we know that at the individual level, communities of color, people of color, are more likely to have chronic illnesses such as diabetes or hypertension or heart disease, and those conditions put people at higher risk for complications of COVID-19 infection. At the healthcare system level, we also know that there are definitely disparities in access to care, and also once people access care, how people are treated. And so prior to this pandemic, we have definitely seen that there's less access to sort of newer treatment, and with COVID, we see less access to testing among communities of color. And then once in the healthcare system, we know that providers actually have bias, and so are less likely to, for example, refer people to procedures for surgeries when compared to sort of white communities. And so there have been stories, for example, of people being sent away from the hospital because they're not deemed to be sick enough, and so not necessarily being hospitalized. And then, of course, there are huge societal issues, which are really the root factors and the underlying factors here. And now we hear this term, the social determinants of health, much more commonly used across the country. And that's really about, where we live, where we work, and where we play, really affecting the health of people. And so we know that communities of color are much more likely to be in crowded housing situations or even homeless. And so people are not able to socially isolate in those conditions. We also know that there are huge differences in employment. So people of color are more likely to have to be essential workers and put themselves at risk for the infection. We also know in terms of incarceration, rates are much more in Black and brown people than in whites. And of course, we've heard a lot about how COVID-19 infections have just been, rampant in jails and prisons. And then finally, immigrant populations are also definitely at risk. A lot of people who are immigrants are concerned about their immigration status and are less likely to access healthcare. So those, really sort of societal factors are key. And they've been present for decades, and now COVID-19 has really exacerbated this.
Well, and that's a great summary of what is indeed a very complex problem. I want to go back to what you were speaking about initially about kind of on the personal level and the problem of obesity in our country. And I've been thinking more about this recently. My colleagues wrote a story a couple weeks ago about how obesity has turned out to be one of the key predictors of really struggling with serious COVID-19 illness. 42% of Americans are obese, and the rates are much higher among African Americans. Wondering if you can talk about that. I mean, it sounds like obesity is a big factor, perhaps even in why our country has seen such a massive toll. How is that? That's a longstanding problem, but what are some ways we could be thinking about that particular problem and eliminating disparities there?
Yeah, so I work in the Bronx, and I'm in a federally qualified health center in the South Bronx, and so obesity is definitely a common problem that I see among my patients. I can also tell you again, really going back to sort of the root causes, when I walk around the neighborhood of my clinic, there are very few options for fresh fruits and vegetables. There's sort of food deserts where people are really unable to get the kinds of foods that are nutritious. And there's also a problem with green space, so a lack of access to, the ability to exercise. So that's just like the environment that people are living in, and that definitely contributes to obesity. And as you said, obesity is one of the underlying conditions that we know that put people at higher risk for complications from COVID infection. And so I think we can't just look at the individual level. We have to look deeper and further, and we have to really examine the environments in which people live.
I know that some have raised concerns that talking about this issue of how comorbidities like obesity and diabetes are related to coronavirus deaths almost seems as though you're blaming the patient or blaming the person sometimes. At the same time, if you can't have an honest discussion of the underlying problems, it seems as though we're not going to get to a solution. What is a productive way to kind of talk about these issues?
Yeah, I think we have to talk about it at all levels, really. So, we tend to sort of in this country, I think, really look at the individual and actually blame individuals. But and individuals certainly have a part in this, and have to really look at their behaviors. And we, as medical providers, really try and help people change their behaviors so that they have more healthy behaviors. So, counseling around diet, counseling around exercise, but it can't just end there, because what we do know from research is that if we make substantial changes in policy, that leads to a tremendous change as compared to the sort of one-on-one. And so we have to think about, again, the social determinants of health, where people are living, where people are working, what the environment is like. Is it safe to go for walks outside? Are there sidewalks to walk in? Are there parks to walk in? And so, we have to have the conversation sort of at both of these levels, at the individual level, but then also at the policy level.
Uh, Imagine for a second that you're the president and you could enact any policies that you wanted to help close this gap on disparities in healthcare. Can you pick out three things you think would be most helpful from a policy perspective?
Yeah, so that's not an easy question, because tackling inequities is certainly challenging. So I would certainly say, at the provider level, we really need to make sure that people are educated and trained to try and reduce bias and really have sort of an anti-racism approach and curriculum. And so education is really critical. I also think if we look at who is in the workforce, that's a really big issue. And we know that there are huge disparities and who, for example, physicians are. So, Black physicians and Hispanic physicians are really underrepresented. And when you have sort of more diversity at the table, then certainly you can come up with answers to complex questions more efficiently, and really getting different kind of perspectives. So I think thinking about, and really creating policies to make sure that the healthcare providers really reflect the population is critical. And then, of course, access to care is absolutely necessary. And so, having insurance, having access to care, it's really impossible to make substantial changes without that. And so, we really have to make sure that everyone has access to care and the insurance to cover that.
You have such a unique experience because I know that you were on the front lines of coronavirus patients and cases, caring for them in New York City. Do you have any anecdotes from that experience that you could share with our audience? And are there any ways in which you feel as though sort of the experience of these patients who are quite ill with coronavirus isn't being fully understood?
Yeah, so I was deployed, like many other providers, to go from the outpatient clinic into the hospital, and I was deployed in the middle of March, and that was when we were in the really steep curve, the surge of COVID-19, and this was in the Bronx. Again, we were hit particularly hard. Um, it was a very, very challenging time. There was incredible fear, incredible uncertainty, isolation. At that time, we really had very little understanding of the virus. And so I personally removed myself from my family, lived in one part of the house, used, a different bathroom, slept in a different area, used different utensils, and really completely separated myself from my family because I didn't want to put them at risk for getting an infection. There was so much that was unknown. Our policies were changing literally by the hour. We were having multiple conference calls every day to say, now you're supposed to wear this mask. Now you're supposed to wear this face shield. Now we're supposed to give this medication. No, now we're supposed to give a different medication. No, now it's in a different group of people that we're giving those medications. And so we really had very little science to guide our care. And it was, evolving very, very rapidly. And so there was constant change and just, again, a lot of uncertainty. One of the most frustrating and challenging parts was, we go into medicine to care for people and to help them be healthy. And we had so little to offer our patients. And our patients were scared. They were alone. And we really had little to offer. And so being in that position was unusual, especially in America. And so that, feeling helpless, but really wanting to help patients who were scared, it was so challenging. And the last thing that I would say was, while all of this was happening, sort of part of the worst experiences was really feeling like we were unprotected. And we've heard that there was a shortage of the personal protective equipment, or PPE, across the country. There was a shortage across the city and the state and New York. And I certainly felt like there was a real lack of leadership to protect the healthcare workers who were putting themselves at risk. Before COVID-19, for example, we would take an N95 mask and we would use it one time for one patient, and then we would discard it. But during COVID-19, we went from that to wearing an N95 for an entire week. And so, which is really unthinkable. And during that entire week, that was what the recommendations were from the CDC for resource poor countries. So I never in my life imagined that practicing medicine in the United States, that I would be following the CDC guidelines for a resource poor country. But that's in fact what we were at the time. So things are now much better, but I'm still concerned. And in fact, when I went back into the hospital in May, like, I would not throw away or remove my N95 mask until I got a new one. And I think that a lot of the medical providers felt the same way. And so, I am very concerned about a sort of another surge in the winter and what that'll mean. And I think we're better prepared now than we were before, but I'm still concerned.
Well, and as you note, we have discovered, I know medical professionals have discovered better ways of caring for patients. We've learned more about the science of this. And I know people have said that has contributed to what we saw. It seemed to be a lower fatality rate through kind of the surge in the summer and the early fall. Knowing what we know now about COVID-19, are there any ways in which you think the treatment would have been different in New York and other places back in April?
Sure. I mean, I wish that we would have known what we know now. Definitely. I mean, we were figuring this out. And in fact, at Montefiore and Einstein, we were part of many trials looking at remdesivir, looking at convalescent plasma, looking at steroids. And this, I mean, this is the quickest the science has moved as far as I've ever seen. And I have my own research studies that I'm conducting. And so this is fast for science that we've learned. And now that we have learned these, of course, we've put, protocols in place, and we see that, there's, despite the increasing infections, the death rate is not as high. And so that's good news. But, it's still, we of course wish we had more. A lot of the medications are really for very specific situations and very specific, patients with very specific presentations, and it's not necessarily across the board. And we'll continue to learn, and we'll continue, to see collaboration between scientists about potentially even better treatments as we go forward. So it is, again, much better than it was in March, but it still, feels unsatisfying.
What's your outlook for the fall and winter? Because on one hand, as we've been talking about, the treatment has gotten better and we are in many ways better prepared. And yet we're also entering the normal flu season, the cold season. People will be indoors more. Are you optimistic, pessimistic? What's your frame of mind on that at the moment?
Yeah, it's hard to know. I guess I'm cautiously optimistic. I think one of the things, really the biggest message right now is for people to get their flu shots, get vaccinated against flu, because that is something we know that we can help prevent. I think it's going to be a little bit chaotic when people have flu-like symptoms. What is that going to mean? What do they have? What are they infected with? You know, so as much as we can do in terms of prevention, that's really the best strategy going forward. So I strongly recommend more than ever that it is now time to get our flu shots. And these are the messages that my patients who in the past have been hesitant to get flu shots are now understand the unique situation and are much more amenable.
I know my colleagues have written a considerable amount about the emotional toll on frontline medical providers, particularly those that found themselves in situations where they were simply overwhelmed last spring. What are some ways that you and perhaps your coworkers sort of managed that emotional toll as you found yourselves caring for COVID patients?
Yeah, it's a huge emotional toll, and I think a lot of us really sort of underestimated how this was going to impact us. It was really traumatizing, and in fact, most of the time when I sort of go back and look at videos or pictures, I become tearful because I just sort of relive that experience. I personally have incorporated long walks and hikes and being in nature as something that helps me clear my head. I also write, and so that's really cathartic for me. And I've written an article about the experience, and along with my colleagues. Um, in addition, we have worked with our mental health providers and collaborated. So at Montefiore, we developed a program where we actually matched the frontline providers with mental health providers and really had regular check-ins to see, was there anything going on? Did people want to talk, or text or email or whatever? And and just making sure that the mental health providers were really there and partnering with frontline providers. In addition, we had things like wellness stations across the hospital where people could just come and be quiet and meditate or listen to calming music. So all kinds of sort of programs to really try and address mental health issues and really the trauma that so many people faced.
I want to talk for a minute about the opioid crisis, which of course was a huge focus in the last couple of years and seems to not be getting much attention now this year with everything going on. But I know there are real concerns that the pandemic could be making it worse again. You've been interviewed several times by colleagues about this. I want to ask a question from one of our viewers. Kevin Doyle from Virginia asks, how should the U.S. reprioritize its response to the opioid epidemic, given the pressing issues of COVID-19? What are the implications of not doing so?
Yeah, so that's a great question. So if we don't pay attention, we will absolutely continue to have more problems. That is for sure. So what we do know is data have recently come out about 2019. So this is pre-COVID, and we know that the rates of overdose and death related to overdose have continued to increase, have continued to get worse. So this is the worst we've ever seen in our country ever, and that's pre-COVID-19. So now during COVID-19, it's really the data are not clear on how it's really affected people who use drugs. But what we do know is that social isolation, which is, again, of course, one of the recommendations when people are infected with COVID-19, that is actually very problematic for people who use drugs, because when people use drugs and if they're alone, they're at risk for overdosing and dying and sort of not having anybody being able to help them. So that's certainly one issue. The other issue that we see with drugs and COVID-19 is that the market for illicit drugs has changed and maybe decrease such that people lose their tolerance to the drugs that they're used to taking. And then all of a sudden, if they go back to taking the same amount, they would put themselves at risk for overdose. So these are real concerns that are happening with COVID-19. On the flip side, there have been substantial changes in the regulations that have really allowed us to provide treatment for opioid use disorder in a much sort of more lenient way, and that's been very beneficial to our patients. So, telehealth is one piece of that. So people do not need to physically come in to the medical facilities in order to get prescriptions or to get their care. We have had provided more medication for the treatment of opioid use disorder for a longer period of time with refills, and again, not requiring face-to-face visits. Certainly, our methadone programs, which is also a main part of treatment for opioid use disorder, has reduced the requirements for in-person visits as well. So I think that some of these policy changes are really beneficial to patients with opioid use disorder. And right now we're at a time to really reassess the policies. Should we go back to the policies pre-COVID? I think no. I think some of our policies were frankly antiquated. And so we have the opportunity to now reassess as we go forward what the policies should look like. And again, they should really be based on evidence and data to get the best treatment for people who have opioid use disorder, because we know that treatment with medication works. It saves lives, and people need that.
Well, unfortunately, that's all the time we have for today. I want to thank Dr. Chinazo Cunningham and Dr. Vivek Murthy for joining us. Thanks so much.
Thank you so much, Paige. A pleasure.
Please head over to WashingtonPostLive.com if you'd like to watch highlights from the program today, and also check out our upcoming calendar of events. I'm Paige Winfield Cunningham. Thanks for watching.